We welcome you all to Talk the Talk. My name is Janine Stiene.
And I'm Toni-Ann Antoniato,
the Masters of Myofunctional Therapy.
Together we interview physicians, dentists, and other professionals to learn how their expertise can benefit you, your child, or your patient's speech and language skills and complement the services they are receiving. We welcome Lisa Paladino to this episode of Talk the Talk. Lisa has been an RN since 1987, a midwife since 2008, and an IBCLC since 2011. She is the co-founder of Breastfeeding Initiative at Staten Island University Hospital and has worked in collaboration with the New York City Department of Health for 8 years to achieve the baby-friendly designation. Lisa is the founder of the Tongue Tie Experts, which provides her audience with educational courses and a podcast. With over 30 years of experience, Lisa is truly a tongue tie expert and has been able to support so many families in their breastfeeding journey, as well as contribute to the expertise and training of other professionals. Thank you, Lisa, for joining us today on this episode of Talk the Talk.
Oh, thank you so much. It's an honor and a pleasure. And, before I come on a podcast, I always look back and see what other guests have been there. And you've had so many impressive guests. I was like, wow. And now they're having me. It makes me feel so special. Thank you.
You've accomplished so much, though, that you're such a good person, not only for people to look up to, but also to see your journey and to see how it's led to so many positive things. I think just makes you that much better as a guest and that much more.
Thank you. Thank you. And it's really almost amusing to me because I never started out to be or to do what I'm doing right now. I never, and if you would have told me 20 years ago that this is what I would do, I would have never have believed you. I was so shy. I didn't like to speak. I didn't know what I wanted to do. I knew I wanted to catch babies. That was it. I was like, so, and then my practice just evolved and honed in on this topic because there was such a need in my area. So yeah, it just kind of happened, which is weird, but I love what I do now. And I feel like I'm in the perfect place for my experience and my knowledge and what I have done. My education has all led me to this place,
A nice organic journey, it sounds like.
Yes.
Nice.
So we're going to pick your brain a little bit, as you know. So can you share a little bit with the audience about what brought you to your journey from an RN to a midwife to an IBCLC and then to the tongue tie community?
Yeah, absolutely. So I became a midwife and, I worked at the same hospital for 28 years. I started as an RN. I always knew that I wanted to go further. I didn't know in what direction, except I always knew that I wanted to be with mothers and babies. And, you had to do medicine first. You can't just be an RN. It's a little different now, but you can't just graduate as an RN and say, okay, I want to work in labor and delivery. No, you got to pay your dues. So I did all that and I don't regret that for 1 minute, learning all about medicine and the body. And back in the 80s, things were a lot different in the hospital. It was actually very, I don't want to say enjoyable, but it was enriching and I learned a lot and I helped a lot of people and it felt good. But I knew I always wanted to be with the mamas and babies. So I got a job on postpartum and then finally was allowed to labor and delivery. And it didn't seem like I ever imagined it to be. So I had this view of birth and it was so different. And I could talk on that for a long time, but I know your podcast isn't about birth. It's about the babies and the tongue ties. So I won't go there, but that motivated me to be able to say, I have to go further. I have to go further. And I learned how to be a midwife and, my master's project, like we had to do a research project. I picked skin to skin, which is the ultimate intervention. And right now, if you think about it, you might say, if anybody having babies, almost everybody does skin to skin. But in 2005 and 6, that was not the case. So I decided that was going to be my research project. We were going to compare the rates of breastfeeding for babies who went skin to skin and babies who didn't. And we had to get all kinds of permissions and all that. My friend and I did this project, and it was my, I needed to do this like thesis project to graduate. So that's what I did. And I sort of became the go-to breastfeeding person on my shift at the hospital because there was nothing going on for breastfeeding. And then New York City did a breastfeeding initiative where they gave all the city hospitals money. But where I lived in Staten Island, we didn't have a city hospital. So my friend and I lobbied New York City and said, hey guys, what about us? So we got a grant, and I'll never forget the day my boss called me in the office and said, Lisa, we got this grant. How would you like a job? So I
Wow.
became the breastfeeding initiative coordinator. I didn't know what I was getting into, but I was like, sure.
Yeah, I love the name. So let's get on my business cards. Perfect.
Yeah. So half of my time was catching babies, and half of my time was administrative things to make policy and try to implement changes. And we never made it quite to baby friendly, but we got close and we improved policies, and skin to skin is a normal practice. I just spoke to someone that works in labor and delivery, and she said, the babies don't go upstairs without the mommies anymore. They all stay downstairs. So I know that that wouldn't have happened if it wasn't for my work. So that makes me feel good. But what happened then was so I got my IBCLC, I got my training, I got my IBCLC because I was being asked to know the things that nobody else knew.
Right.
And I started to see babies that I couldn't help with what I learned as an IBCLC. All the tricks, all the positions, all the this and that. There were some babies that just could not latch. And I had 3 babies in 1 week. And the third baby had just come back from getting a tongue tie release. And the mother said, I'm really, I almost don't want to tell you this because it was like a secret, I went to this doctor and he used a scissor and he cut my baby's tongue tie and now he can nurse. And light bulbs went on because as a midwife, I was very non-interventional. So I was one of those people saying, why would a baby need a procedure? Because I didn't know.
Right.
Right. So I started opening up my mind, went to conferences, did some in-person shadowing with Biggie, Dr. Scott Siegel. We are fortunate to have him locally. I spent a lot of time in his office, picking his brain, emails back and forth about patients, learning all I could from other lactation consultants who also were doing this in other places. And I just became the go-to person because nobody on Staten Island knew anything about tongue ties. And I remember thinking, like, really having that moment of why me? Why am I qualified? And Dr. Siegel said to me, Lisa, if not you, then who? Because there is no one else, and you know more than anyone else right now. So that inspired me. He's a wonderful man.
He is a wonderful man.
Inspirational. He's inspired so many of us. And then he decided to have a conference. And I don't know if you guys remember the conference he had in New York City. I think it was 2017, 2018.
Okay.
And he told me he was having a conference, and I said, can I speak? And I had never done public speaking. Like, what am I going to talk about? But I was like, you know what? I want to speak. I just felt called to share what I knew and share the protocols that I was using that was working. So make a long story short, my practice has evolved from that moment because I still feel like I know how to take care of these babies. I have honed my practice, my collaboration with other team members. I know how important timing of this is. I know how important educating the parents are, and individualized care. So that's why I pour all of that into my courses, my podcast, this type of work, because I can't see a lot of babies, right? I can't see everybody. I need to train the next generation, So that's my mission. And, that's where I know that was a long answer, right?
No, it's so funny that you say that because that was actually going to be my question. Do you feel like that next generation has to follow the same trail, the same path you did? Or do you feel like there are parts of it that could be omitted and still get them to you where you are, what you've succeeded at?
That's a great question. I do feel that when I started out, if I mentioned tongue tie among colleagues, I got like deer in the headlights look. At least now people know about it, right? Even the fact that many more people are at least attempting breastfeeding than when I started my work. You know, I think the rates at the hospital were like 20% of initiation when we started the work. It was ridiculous. Especially Staten Island was a unique place because we're like geographically isolated. We're part of the city, but different from the city. And all the medical professionals are sort of in, and I feel safe to say this now, it's like one big club, you know, and they don't learn anything outside of what the club, you know, echoes back to each other. So at the time, it was very, very difficult. Now people's minds are opening up. And because, you know, this is why I love social media, you know, and I have a big presence as tongue tie experts on Instagram. It's not because I want to be an influencer. It's because the need is there because families are not getting this information from their providers. So now we make it a consumer-based need for providers to learn because the families are asking for it. If they don't help them, they go somewhere else. Or that's the successful people. Some people just drop off, you know, but they're looking for help and they're not getting it. If they're not getting it at their local doctor's office, they're going to turn to Google or Instagram or TikTok or whatever. No matter what we think about how that shouldn't be, what else are these people going to do?
Right. Yeah.
Right.
When
So
the parents are the ones demanding it, then
yeah. So
to
to answer your question, I do think it's easier now. We've had a little bit of a setback. You know, there's been some bad press about tongue tie treatment. And that caused a little bit of a setback, but I think, you know, we're recovering from that and recovering from it in a stronger way. It's part of the reason why I keep advocating for the right treatment, not immediate, not, you know, oh, just clip this and forget it. We have to make sure we're doing things right and individualized and get the research-backed information as much as we can with this field. It's a challenging field. So yeah, I think it's easier. Hopefully it's building. You know, it's like 2 steps up, 1 step back, 2 steps up, 1 step back. It's not a
Yes. Okay. That makes sense.
Sometimes because we emerge ourselves in this space and this airway space and going to these conferences and tongue ties and Myo, we feel like, you know, there's that shift is happening. But then sometimes like, is that just our bubble still? Because then we'll get, you know, the people that are like, no, there's, you know, this thing is a tongue tie.
You know, for example, I went out to dinner with old friends last night, like couples that we used to hang out with, and I haven't been out with them for a while. And I was trying to explain to them what I do. And these are all people around my age. They're musicians. My husband's a musician, so they're like musicians and their wives. And they were like, I was like, well, you know, and I'm almost like embarrassed to say tongue tie experts because people don't know what I'm talking about. You know, all I say is, well, it's this specialized niche field that I have a following in because there's a need for it in certain populations. And
even though we all have a freenum and yours can be restricted.
Right. But not everybody. I mean, these aren't people who ever breastfed or thought about breastfeeding their children, you know, and now their kids are grown up and, you know, whatever. It's just funny. It's like, yeah, I do this thing, you know.
I'm sure there was someone sitting at the table with a tongue tie and didn't
Oh yeah, there was.
That's the worst part.
Who's got sleep apnea? And I'm looking at this long, narrow face with the dark circles and being like, I wish I could help. No, it's so hard. It's so hard sometimes. I just got a card. One of my really good friends has a grandson, and they sent the birth announcement. And in 2 of the pictures, the baby's mouth is hanging open.
Oh.
And my daughter saw her yesterday and she said, I'm so glad I'm not breastfeeding. It makes it so much easier. She was getting her hair done. I was like, whatever. And here this kid, you know, it's so frustrating. It's so difficult when you know, I'm sure you guys know, right?
Yeah.
You see it everywhere. You want to help everyone.
I know.
But you can't.
You can't.
They have to
Yeah.
want the help sometimes.
Mm-hmm.
Yeah. What do you feel like, we still have, what hurdles do we still have to come by, especially when it comes to like the education, and the medical, profession?
Yeah. I'd say that the biggest obstacle are medical professionals not knowing what they don't know.
Yeah.
So, and I'll head that off with the capital P,
Yeah.
pediatricians, because they don't know. And you know what? If you're a pediatrician and you're watching this, more power to you that you're here watching.
Mhm.
But
Yeah.
for the most part, like I don't ever want to insult anybody.
Of
But for
course.
the most part, what I see in my experience since I started this is if a pediatrician didn't learn it in school, he doesn't know it. And and I almost can't blame them because they have a very difficult job. You know,
Mhm.
I would never want to be a pediatrician
Mhm.
because their responsibility, their pay is not amazing,
Nope.
it's unless they're running a huge corporation practice, they're really not making good money. They're working their butts off. They have 10 minutes to help a family,
Mhm.
and do all the things and all the things they're responsible for. So there's that. However, I didn't learn this in school. You didn't learn this in school, and we know it.
Right.
So it behooves them to learn more. And that's the missing link.
Mhm.
Because that's why the last statement from American Academy of Pediatrics just put me like over the edge. I was like, if you don't, they said there's no research and then quoted research. Like they didn't even, it was just so frustrating because there was
Yep.
research that they didn't include that could have helped them. It was like if it wasn't done by a pediatrician, it's not research.
It's crazy.
You know?
Yeah.
So
Yeah.
whatever.
And I
That's
think
that's
too,
our obstacle.
when it comes to that, is that if you don't know, just make the right referral, not tell someone it's not a tongue tie if you're not
Yes.
able to assess that. Let them
Yes.
go to the right people to figure out if it is or isn't.
Yeah. Back to social media. One of my most popular posts is if you don't know how to assess for tongue tie, please don't say there isn't one.
Yeah.
Yes.
And I get comments and stories from families that just break my heart.
Yeah.
All about how many people missed, and I'll say, who missed your tongue tie? Who missed your
Yep.
tongue tie?
Mhm.
And the stories, the pain, I get instant, private messages saying, my baby had this, and this, and still nobody will listen to me. What should I do? And it's really, really sad because I really feel that in our society, we have taken mother's instincts out of the equation. If a
Mhm.
mother feels like something is wrong, we should listen to her because
Yep.
99% of the time she is right.
Yeah.
Right. And we get, oh, mommy, stop it, from the doctors, or like, oh, you wanted to do that cute thing called breastfeeding. Oh, well, there's always the bottle. And
Right.
I've heard so many insulting things said to parents. And it's really that's the thing. If you don't know, if you don't want to learn, send to someone who does. And if you
Right.
want to learn, there's courses like mine. There's
Mhm.
lots of education out there.
Mhm.
The conferences that we go to. I belong to ICAP, which is to me the most amazing and evolving organization because they're doing real research with
Mhm.
real scientists doing the research, and yeah, it's good. And you get the networking. I wish I made money from ICAP because I'm always saying ICAP.
Yes.
Like I
You're like, I
promise
need
I'm not on the payroll. I think it's in you walk into a room like that, and like you were saying before, you feel like you're with your people.
Yeah.
Yep.
You just feel like everybody around you wants to learn
Yeah.
and
Yep.
learn interdisciplinary.
Yeah.
Yes.
Yeah.
That's why I let everyone in my course, any professional, anybody who works in the birth community, doulas, midwives, doctors, OTs, PTs, chiropractors, osteos, anyone who wants to learn,
Mhm.
because, a lot of lactation courses or lactation based or taught courses only allow other lactation consultants.
Okay.
But I know that most people never make it to the lactation consultant.
Right.
We
Right.
all need to know, and we
Right.
need to know what each other does.
Yep.
So I've gone to speech language pathology
Right.
conferences and heard speakers, you
Mhm.
know, I would, because I need to know what you know, which
Yeah.
I never knew before.
Right.
I
Right.
never knew what an SLP did. The SLP I knew in the nursery was the one who she was anti-breastfeeding. She would even say it. She didn't like breastfeeding. Now, this is 35 years ago, right? So she didn't like, you could say that and get away with it. She didn't believe in breastfeeding. Her kids were fine and they got bottles. And she would do feeding studies only with a bottle. So I would have exclusively breastfed babies, and then she would be giving them a bottle of formula. So
Yeah.
that was what I thought an SLP did. I was
Right.
like, you know,
Yeah.
Stay away from them.
Yeah, exactly. They don't support my vision.
yes, but things have changed, thank goodness. Thank goodness. In my view, I network with SLPs, and one of my closest friends is an SLP, and we share patients all the time. And I don't know what I would do without her. We complement each other's practices beautifully.
I was just going to say, everyone has a place.
Yeah.
Do you feel that most or things have changed in terms of how people find you? Do you feel it's the mothers directly now, or more so now than the doctor, or is it a combination? What do you see happening?
It was never the doctor.
Wow.
No, it was never the doctor referring me. If anything, I almost have like possibility, like grounds for lawsuits against some of the doctors and what they've said about me.
No
And
way.
Dr. Siegel. Yeah, it's pretty bad, but we can't exactly, it's like third degree hearsay, you know?
Yes.
But when I started out, the WIC had peer counselors, and I helped train the WIC peer counselors at the hospital. And some of the girls had started a Facebook group, and it's still going. It's called Staten Island Breastfeeding Moms. And they were like, Lisa, we want you to be in it because you are a medical person. We're just peer, like mother to mother support. We need somebody that really knows what they're doing to like kind of gatekeep and guide the conversations. So I joined that group. I've been an administrator of that group since like 2006, right? And so anytime anybody needs an IBCLC, it used to just be me. I never had to advertise. It was just like, oh, go to Lisa, go to Lisa, go to Lisa. And now there's more. And there's even somebody who did a little training with me that now has her own practice, which is cool. And there's others in the area, thank goodness, because, you know, how much can I do? And,
You seem really busy, Lisa. I'm just saying.
Yeah. But my clinical practice is like right now it's closed because I moved. So I was in Staten Island and now I'm in New Jersey. And my office was in my house. So I don't really I have the ability to meet patients in somebody else's office. My SLP friend, actually, or my OT friend. And but that's not my focus. You know, right now it's more important for me to reach other professionals. And it's hard to do both, as you guys know.
Yeah.
It's really hard to do both.
It definitely says a lot about your character too, that you just keep pushing through even when people are not always being the most nice about it.
Yeah, it's all right. It's their problem, not mine.
Yeah,
Exactly.
And the patient's experience is what matters.
Yeah.
And when other women are saying, you have to go to Lisa because she was the only one who understood. Now, I'm not special. That's the whole thing. I just knew things that other people didn't know. So that's why I'm so passionate about teaching, because I want everyone to know what I know. I want everybody to be able to understand, no, don't do this, do that, or, you know, this is what you should do in this situation. Understand proper assessment, and proper assessment is functional. All of my social media, I do not allow anyone to post a picture and say, do you think this is a tongue tie? Nope. Unless there's a story with it, you know, because this is about function. It's not about what it looks like, especially in a newborn. We don't know about tension patterns and all the things that could be going on. So maybe there's a frenum there that looks restricted, but maybe mom's got no milk, or mom isn't putting the baby to breast. That's why the baby doesn't want to feed, or she doesn't know how to hold the baby because she's never seen anybody breastfeed. So there's so many things that go into breastfeeding, and pain and comfort measures, and just knowing how to demand breastfeeding without it wearing you out. There's so many things that go into it that just that picture is never the right way to assess or diagnose something. So we go, I teach different methods of assessing for people who never even can look in the mouth. There are some providers who come to my course that's not in their scope,
Right.
but they don't need to in order to know who to refer to if
Right.
things are going on. So yeah, it's inclusive interdisciplinary teaching is my goal. I want everybody in the same room.
Who do you think needs the most or most education at this point in order for you to see a mass change in the field? And
Yeah, I would say
specific?
I would say the first level of contact. So whether that be the doula, the midwife, the pediatrician, the nursery nurse, if there's still a nursery in the hospital, the NICU nurses, the OB and postpartum nurses, the people that see the babies first should at least know if there's this, then we have to triage to that. You know what I mean? Not to be sending right for a release, but at least having an IBCLC to refer to. And getting back to what we started with, that I worked on the baby friendly project. The baby friendly project, one of the steps is a referral system for after discharge. You don't just let somebody go out of the hospital breastfeeding with no safety net. So there should be a recognition of possible tongue tie, possible oral restriction, with anybody who's having difficulty feeding or nipple pain. Any baby that does not latch should be seen, referred to an IBCLC with training in tethered oral tissues. So that's the gatekeeper, because so many people don't make it past that point.
Right.
Yes.
Right? Like, I know this is the other thing I say. I don't teach about breastfeeding because I got this right. I wish I had somebody like me when I was having my babies. It took me to my third baby, who was 8 years after my second.
Wow.
It took me to that and having a home birth so that I could breastfeed right, because the hospital interfered back then.
Wow. Well, I was going to say, I do feel like that's a lot of it, is that they're breastfeeding, but not breastfeeding correctly. We get that question all the time. I breastfed my baby for X amount of period of time. I've done everything right. Why are they still presenting with a tongue thruster? Why do they still need myo? And a lot of times it's just the way they're latching is not correct.
Right. And you know what? I've had people come to my office and say, I'm here because the baby's not gaining or the baby's got reflux, but it's going great. And when I see the way they're nursing and the patterns of nursing, I'm like, really? That doesn't hurt? Or, the baby's popping on and off, or they're not getting a deep enough latch, or, and any amount of breastfeeding is better than no breastfeeding. But there is a category of women who have ever breastfed, who, if you've asked if they breastfed, they say they did, but maybe they had to start bottles right away, or they were doing mixed feeding from day one. And I see this a lot. They think they're breastfeeding, but the baby's getting all their feeds from the bottle, and their baby's going on to them for comfort. And then at a certain point, the baby's like, I'm not going to bother with this. They get to like 3 or 4 months, because I'll say, well, how many bottles are they getting a day? Oh, after every feeding. Like, well, then why would they nurse?
Right.
And then you're not getting the open mouth posture and all the things that you need. But we don't even know for sure, which is a shame. Like, how do you know for sure that proper breastfeeding is going to prevent other problems later? We really don't.
Right.
We really don't. And anybody who claims to is lying. I just feel like we want to optimize whatever we can.
Right.
Because we know that the way we eat from day one into childhood, into adulthood, is not good for our oral structures. We know that. So let's optimize it as much as we can. You know, one mother baby diet at a time, one child at a time, keeping it going. I'm still battling my oral structures. I don't have it in now because I speak funny, but I'm doing Invisalign. I'm having a little expansion going on with that, which is so exciting. And, you know, I've done my tongue tie release. I've done Myo. I've done, you name it. I've tried it. I practice what I preach. And, it's a challenge because I was bottle fed. I was on, um, cow's milk at 3 months old because I gained my weight.
Wow.
I gave this fact the other day in an interview, and my mother used to say that my pediatrician told her that I had a flat head, so I should sleep with a rolling pin under my neck. So I had plagiocephaly as a newborn.
Wow.
Yeah, so like you do what you can, you know?
Right.
So true. So true. Wow.
And I had reflux. She would say, when I had my kids, she'd be like, "Oh, that's not spitting up. You used to spit up across the room after every feeding of cow's milk at 3 months old."
That answers a lot of my questions.
Wait a minute, I get it now. Exactly.
Yeah, I know. So that's why I can't tolerate dairy now.
Yeah.
Get it? Okay.
I get it now. I get
Anyway.
To the moms, what are some of the red flags that you would tell them to look for, to consider, especially if they have a pediatrician telling them there's no tongue tie? What can you say to them to, guide them for where it might be appropriate to get a opinion of an IBCLC? Or
So I have a whole list, but I like to think about it as mother symptoms, infant symptoms, and feeding symptoms. So in mother, if there's pain, but if there's no pain, that doesn't mean there's not a tongue tie. But most people who are feeding a restricted baby do get nipple pain. Most, not all, but most. If she is having a delay in her milk coming in, and this goes into feeding, if the baby is not gaining, or there's any reason that the pediatrician wants her to supplement with something other than her breast milk, then she needs an IBCLC. And that should go hand in hand. If I could create one thing for pediatricians to know, it would be, if you think that the mother, her milk isn't doing its job, then she needs an IBCLC and she needs to start pumping. So the first choice for supplementation should be mother's own milk, not formula. But pediatricians miss that message, even though it's in their American Academy Pediatric Statement on Breastfeeding. It's been there for 30 years, but they don't believe it. So there's nothing special about formula for weight gain. It's just volume. So let's get the volume from the maternal milk supply if it's possible. And if it's not, even if you don't want to use that milk, if she does not pump in the beginning, she's going to lose her milk supply. Right. So, so in the baby, it's lack of latching, having difficulty popping on and off, not sustaining a deep latch, not gaining enough weight, jaundice, believe it or not, because that's all jaundice is often a symptom of not having gotten enough, right? And they start treating for jaundice, take away the mother baby connection, put them under the lights, and it's like a whole cycle of interventions that's a no-win situation for the baby.
Got it.
So any jaundice, reflux, wanting to eat all the time. So even a newborn should have a pattern where they eat for a bit and then they have periods of settling. If that baby is never settling, then that baby is never getting enough milk. So again, IBCLC, is it necessarily a tongue tie? We don't know that. Maybe it's a mom milk supply issue, or maybe it's trauma from birth issue. Maybe it's a torticollis issue. But if the baby isn't nursing or isn't getting enough by nursing and always seem to be hungry, they should get an IBCLC consult. And be really careful about lactation consultants can mean anything. There's lots of levels of lactation help. I have heard people say they had a lactation consult and it didn't help them at all. And then I like to say, but was it an IBCLC? Because you can take a week-long course and call yourself a lactation consultant. An IBCLC is intensive, years of training, testing, retesting. I had to retest last year. Fun stuff.
I can speak the truth on that because I am a certified lactation counselor, but I did it to complement my speech.
Right. I love that combination.
Yeah. But yes, it wasn't by any means comprehensive. If I didn't have my speech background and I did just that, I wouldn't know what to do.
Right. Because you're just a counselor. So the counseling part of it is beautiful because you're allowed in the mouth and you know the structures. But if a lay person becomes a CLC, and we need them. I started as a CLC. That was my first step into IBCLC. We need CLCs. But if your CLC is not helping you, go on, go to the next level because we're the gold standard, as gold standard. And we know more. And different IBCLCs have different knowledge bases, And I would be honest, if somebody comes to me and they're like, I need help with pumping, that's not my jam, and I'll say that, I'm not the one to help you. If you want to exclusively pump, I support you, go to her because she knows that. Or like inducing lactation. I don't do things like that's just not my jam. Is it important? Is it beautiful? Yes, but it's not my specialty. And I think that we should all recognize that in our own fields. Like we refer out to the people that are the best at what, that patient needs,
I know there's been a lot of talk about a developmental protocol when it comes to identifying a tongue tie and when to intervene. Just like when you go to the pediatrician and they ask, is your child sitting up? Are they making sounds? How much closer are we to having such a protocol that the medical professionals at least can be driven by? Because if you're a parent that doesn't know that some of those symptoms are going to be a sign, and then you go to your pediatrician and nothing's ever mentioned to that end, you may just go in this vicious circle of trying, failing. Are we any closer to having something like that? And
I don't know if we'll ever be that way. I know, some countries like Brazil had a frenum inspection law, and that was not ideal because, okay, the baby looks like they have a tongue tie, but babies, and this is controversial in the field itself. We used to say, release that frenum as soon as we can. And there's professionals who say they've done it in the delivery room. I do not, or straight from the delivery room. I do not agree with that because we don't know yet what's unfolding for that baby and that mama. And they haven't had a chance. And there's so many things about this, about recovering. I believe you guys have seen my, what about mom talk because, what is this? Oh, your baby has a problem and we have to do surgery on your baby. That's what they hear, right? So we're going to tell them this in the delivery room? No, because maybe that baby's tired from birth. Maybe it's not causing a problem. Maybe the baby needs an adjustment before. Like there's so many things, so many things. So I don't believe in immediate release anymore. So I don't really want people who don't know what they're doing to get gung-ho about referring for release. We have to start the paradigm of treatment isn't necessarily release. Treatment is assessing the whole dyad and seeing what's going on.
Right.
Yeah. And I'm sure like that works for older kids, right? Like you don't just, it looks like a tongue tie, let's go do it. No, you make a care plan about it. So I'm afraid that any standardization doesn't take into account the individual situation going on. And many of the babies back when we started this and we're doing it sooner rather than later, many of those babies needed another release, including my own grandson, right? I have his example as a great learning experience. which is a shame, but he was one of the most challenging babies I've taken care of. And, my daughter didn't want to do the release, and I didn't blame her, but it was getting increasingly more painful. She was blessed with a copious milk supply, so he was doing okay, but she was dreading nursing. So we knew he needed a lot of body work. He had things going on with his palate, and he had a little torticollis, and he was stuck in an awkward position during the pregnancy. And she's pregnant again, and she's like, Mom, baby is in the same damn position. And she's only 20 weeks. I'm like, well, you better start moving.
Exactly. Jumping up and down or something.
So she had a sonogram. I'm trying to look at the palate on the sonogram and the angle.
It is funny how we stick in our own brains, right?
Yeah. But anyway, so we knew he needed more work, but this is what I tell parents. If you can't do it, have the release, but know that might not be the be all and end all. You may have to have the procedure again. And he did have the procedure again when he was I think he was 16 months. After a lot of body work. He's still doing, he went for an osteopath treatment the other day, and he loved it. Now he's 3, so he's getting it, and he's got some tightness in his hips, right? And the hips relate to the jaws. It's an ongoing process, So I think that there are protocols. What I like, the protocols that are being set up now. If you're familiar with Dr. Rajiv Agarwal, he has what's called the FLIP tool, which is it's an assessment of breastfeeding where it's mother generated. So she answers questions, and it's not, does my baby need a tongue tie release? The answers are, what are the degree of possibility or probability that breastfeeding isn't going to work? So what does she need? She needs interventions if it's a certain percentage. And to me, that's beautiful. It's a very easy scale. You don't have to have a degree. You don't need to look in anybody's mouth. It's symptom based. And it's maternal reporting, because it's the mother's experience that matters, really.
Right.
So I like things like that. And I don't know, I know ICAP is doing a lot of research on tongue versus lip tie, and relief of symptoms after procedures and things like that, and aftercare. We're looking at aftercare very closely. What should be the best aftercare, because those protocols have changed a lot since I started out.
Even now, the level doing the myo before release and after release, that's changed in the last 6-7 years. It used to be just post.
Right.
When I started, it was not immediately post. When I first started in the field, it was you got to wait till all the healing's done and then intervene.
Right.
Just like you said, things have evolved so much.
Things have evolved, and we're doing the best we can every day. And it's really difficult to do research on babies, really difficult morally, right? And what I like to point out is, as a midwife, I know that a lot of the procedures and medications that we used in the delivery room did not have a lot of research. And some of the medications we used were not even FDA approved for what we were using them for. Why is that okay? Right? But this isn't okay, because we don't have tons of level 1 research. We have tons of experience. First, do no harm. Nobody's trying to hurt babies. You get a bad apple in every field. That bad apple, or that bad situation, or that bad turnout should not cloud everything for everyone. It shouldn't shut us all down. Oh, go away, you pesky tongue-tie people. It shouldn't be like that. And I can honestly say I have never sent a baby for release where the parent said, I wish I didn't do that. Ever.
Yeah. So true.
And my patients come back, they refer their friends. I don't think they'd be doing that if I was hurting babies, or, God only knows I'm not getting rich off this. That's the other thing we're accused
rich and
of.
aggravation, maybe.
We're getting kickbacks,
Oh gosh,
all the
we
things.
hear it too. All the time.
Yep.
But and what you were just saying too, I was thinking before when you were talking how we're much more acceptable of putting them on a reflux medication than we
Yes.
are of making a referral.
And
or
there's
calling
research
a
there saying how harmful it is.
Right, right. But that's
It doesn't
socially
make any
acceptable.
sense. It doesn't
Mhm.
make any sense.
Right, right.
But
Are
the
you?
doctor said, so
Yeah, exactly. I know recently, this was somewhat newer, maybe in the last year or two,
Mhm.
that a lot of professionals are like, stop calling it colic. There's no such thing as colic.
Right. Colic's
There
a
is
symptom.
Yeah. Mm-hmm.
Colic's a symptom. Yep, absolutely. And
Does
even reflux, we put names on everything now. Like I was just saying, and this is a little bit off the topic, but it's true.
Mm-hmm.
When I was a kid, you either had a stomach virus or a cold.
Yeah.
Now my niece was like, I don't know if I have flu A or rotavirus or this or that or COVID. Like, yes, you have a cold.
You're
Right.
sick. Yep,
That's
exactly.
what we call it.
100%.
Like, let's treat the symptoms of your cold.
Yeah.
Oh my God, you're so right.
Yes.
Like
Does it matter? Right.
my husband's like, oh, so and so has got norovirus. I go, do you remember when you couldn't get out of the bathroom? That's norovirus.
Yeah,
You have
exactly.
to
You
have a
had it
name.
also.
But now it sounds like,
I know.
I know.
Yeah.
It's so true.
yeah. So reflux has increased. Why has reflux increased?
Right.
The diagnosis of it has increased
Mhm.
because people are labeled. Oh, does your baby spit up? Yeah. Oh, you better take medication.
Right.
Yeah. Babies
Mhm.
spit up sometimes,
Yeah.
but it should be if it's on a regular basis and the baby's. I love silent reflux.
Yeah.
Like, I think my baby has silent reflux. Why? Well, I don't see any reflux. I'm like, so why are you assuming they have reflux? Like, yeah, we're looking to medicalize too much.
Yeah.
Okay.
Mhm.
And I think the internet has really WebMD and all the Googling that people can do.
Right.
Yeah.
I mean, I'm a neurologist, at one point, and I'm a plumber the next, I'm very talented.
Yes. And I like to say, I said before, I think the power of the internet to educate is important.
Right.
But we have to be discerning. Like, just because a woman has 3 million followers and she had a baby, she's not an expert on baby care now.
Right.
Yeah.
And she's, whatever, selling a product for the bottles or whatever. Doesn't make her anything special. She didn't get a degree. So, like, look where if you're a parent listening and you go online, just look at the resources of it. Look at, what's behind the person saying what they're saying,
Yeah, definitely. And you're 100% right about that. And I never put that into words, but we quantify someone's level of expertise on the internet based on, like you said, the number of followers they have, which, has nothing to do with their background or what they actually know.
Right.
It's so true. Wow, that was just a great way to put it. And I couldn't agree with you more.
You ever scroll through and you'll read something and you go, really? And it's about something and you're like, I didn't know that. And then you're like, wait, true.
Oh, yes. Yeah, I can't tell you how many things I said to my daughter. She's like, that's fake. I'm like, oh, okay. I didn't realize.
Especially if you know it. Especially if you know
like, wait, really? There wasn't that many rats running around London last night? She's like, no. I'm like, okay.
Yeah, like, I'm a very big New York Mets baseball fan, like obsessive.
Oh, I'm a Yankee
right? Like,
fan.
my puppy is named after Francisco Lindor. That's his middle name.
Yeah.
All right. So we're trying to sign our first baseman, and he's not signed yet. But every day there's a fake story that makes me click that says we either signed him or we didn't, Pete Alonso. And it just makes me crazy because I really fall. I'm like, oh, we got him. And I'm like, oh, wait, no, we didn't.
It's so true. So
That's
true.
clickbait.
That's exactly right.
Yeah.
So there are these people that are out there saying, if you use this bottle, your baby won't have colic. And there's nothing behind it. There's absolutely, it's just that a lot of people have said it.
Yeah.
And that's.
So fundamentally, do you feel that every woman has the ability to breastfeed successfully?
I know that as a species, we are meant to feed our babies at the breast, right? So much goes in the way of that, right? So if you think of us as mammals, and that's what we're supposed to do. But then we have real world, real life. There's so many people who can't breastfeed because they have to go back to work in a week. I mean, I helped medical residents when I worked at the hospital who were on call 2 weeks post C-section and trying to pump away. So everybody can, depending on circumstances. But if you think about, if you're healthy, you have no problem, you didn't have any problem conceiving, you haven't had breast surgery, you have nothing physically wrong with you, you didn't hemorrhage at birth, you didn't have a lot of traumatic interventions at birth, there should be no reason why your milk won't come in. You don't have thyroid disease or PCOS. There's a lot of risk factors and red flags for not getting enough milk. But that's only about, I'd say, 2 to 5% of women. Then there's all the women that things were done to them, whether they were needed or not. I'm not going to argue that, but things that interfered, like if you have a C-section, whether you need it or not, you're going to be at risk for delayed milk coming in. So then you're in pain, the baby's hungry, the bottle of formula is there. What are you going to do? You're going to feed the baby, right? So there's a lot of obstacles, women are having babies older and sicker because as a society, we are sicker, right? I mean, there's so much chronic disease, diabetes, heart disease, pulmonary disease, inflammatory conditions, autoimmune disease. So going into it, you automatically have a lower chance of this being successful just because of all the interventions that are going to be done to you. So there's that. So I always like to say, if anybody has a risk for low milk supply and they want to breastfeed, they should meet with an IBCLC before the baby comes.
Right.
If you've had a baby before and you didn't exactly meet your goals or you struggled, meet with the IBCLC in your third trimester.
Right.
And talk about what happened last time and what you can do to troubleshoot so that doesn't happen the next time. Some of my favorite work is on my prenatal consults where we unpack what went wrong. Or if it's a first-time mom, I like to talk to her about doom and gloom. I'm going to tell you all the things that could happen and what you're going to do or say. Like nursery nurse comes in and says, I think we need to give the baby formula. Well, this is what you should say. Does my baby need formula? Can I pump? Can someone help me hand express and give? And so on and so on. Being prepared is key. And having someone whether it be a family member who's breastfed before or having a relationship with a CLC or an IBCLC before the birth is key. Because you're not in a place to look for that afterwards.
Right. Yes. Right. And do you feel like when they're looking for the IBCLC, they should be looking for that full team approach, meaning someone that has the access to the body workers and the speech pathologists and the oral surgeons, like looking for someone that
ideally, yes. But I know that there's not so many, especially in rural areas in the country and in other countries too. There are centers. But what you can do, and I always, I have a handout as a part of my course, or parents can even download it, what questions to ask a provider. And one of the questions that you don't want to just like, oh, I think my baby has a tongue tie. It looks like I have all the symptoms. There's no IBCLC here. What should I do? Well, you want to go to someone that answers the questions right. And one of the questions is, do you work with IBCLCs? Do you have a network? And ask that dentist who they recommend, and I know in our area, that's, amazingly how my practice has grown a team in a networking kind of situation, both in, with the Dr. Siegel situation. And there's a doctor on Staten Island now, and we brought him and he took me out to coffee. He was like, I want you to refer to me too. And I'm like, well, not until I come to your office and see what you're doing,
Right.
And then we met and we had a mutual friend. And now, we just had a beautiful situation with a baby who saw me first, had called the SLP that I work with because she had a problem. Her first baby had a real oral dysfunction, and we didn't get that baby till 4 months, and it was a sad situation. He couldn't even take a bottle. Because that's the other thing. This isn't just about breastfeeding, as you know.
Right.
Yeah.
It's about breastfeeding. So this baby, she came to me 3 days old. I recommended my OT friend who does CST. He had treatments. She was still supplementing, even though she didn't need to because she was afraid. Both of us gave her the same messaging. She wanted to have the release right away. We spoke to the dentist and we said, listen, he's not ready yet. We have to get him at breast. We did all the things, like we coordinated, worked together, and he just had a release yesterday, and they're doing amazing.
Okay, so I think this last question, Lisa, we could talk to you all day. Honestly, I could literally pick your brain all day. As an IBCLC, are you, in the event a mother cannot breastfeed, are you giving them the same type of advice when it comes to picking a bottle or picking a formula or picking a pacifier type?
Mm-hmm. That's a great question. So, because of my close association with an SLP who understands bottles much better than I do, I have a list of what I will say, and whether it's a mother who's supplementing because she's, needs a bottle here and there, or she's completely bottle feeding. But if I have a complete bottle feeding mother, I refer to the SLP.
Okay.
I always say to limit pacifier use, right? And that comes just not from what I've seen professionally, but also my own personal experience. We were talking about me before. I had a pacifier till my mother told me that the bird came and took it off the windowsill, right?
Wow,
I love my
that's a
pacifier.
talented bird, huh?
Yes. She left it on the windowsill in Brooklyn, and the bird came and took it. And my own kids had pacifier addictions and had consequently the orthodontia that went along with it.
Right.
Yep.
Pacifiers for emergencies, for in between, not to keep in the mouth. There is no magic pacifier.
Right.
There's pacifiers that are better than others, but they still should not be used a lot, right?
Mhm.
Right.
Limit it when possible.
Mhm.
And I feel like what I do for parents who are bottle feeding or mostly bottle feeding even, and even breastfeeding moms, I'll tell them other red flags to look for on the path, because there's always, the ultimate reason we're all doing this is airway health, which I didn't know that when I started, but right
Of course.
now
Yep.
I know. So, if baby's got open mouth posture, if they are making any snoring noises, if they are very restless sleepers, if they have difficulty with the bottle when you try it, if they can't drink from a cup, they dribble all over the place, if they can't chew food,
Yeah.
all the things, and they're not meeting speech milestones, like reach out sooner rather than later.
Right.
So I don't know half of what I say, probably, because I put out so much information to my patients that I'm like, they're never gonna, but maybe something will stick,
Yes.
maybe something will stick.
Yeah.
Well, and then we're going to play this in our waiting rooms in our 9 locations. So
wow.
At least our patients and our families will see it directly, as well as obviously we'll post it. But hopefully some or much of what you said is going to be a support to many of our patients and the masses as a whole. So we really appreciate you taking the time to talk with us today, weather all the technical issues that we had, but really giving us an education as much as giving our audience an education. So
it was a pleasure to be here. I really appreciate that I was invited, and it's an honor to be able to share what I know. Thank you.
And before we go, just let the audience know a little bit about where they can get more information on you and your courses, especially all the professionals listening.
Yeah, so tonguetieexperts.net, because .com was taken, is my website. And the Instagram is Tongue Tie Experts. Instagram and Facebook is Tongue Tie Experts. And anybody could ever just email me at Lisa at tonguetieexperts.net with any questions. And usually I'll have a handout. I don't have as much handy like right up front for parents anymore, but I do have things for parents. So if anybody's looking for information, I can shoot them an email.
Perfect. Thank you so much.
And the podcast. I didn't mention my podcast.
Oh, yes.
The Experts podcast is a great resource for anyone wanting to learn, because I've interviewed many different types of providers, and I've had parent stories on there, both as a parent with a young baby and then grown-ups who've gone through treatment for their airway disorders. And I love, and then I blurb on things, some of the episodes are just me talking about a topic. Like last week's episode was white tongue, right? So white tongue, does the baby have thrush or does the baby have a tongue tie? Right. Yep. So I went into that. So there's a lot of information. There's so many episodes, and we're just celebrating a 3rd anniversary of the tongue tie.
Wow. Happy anniversary.
Thank you. Congratulations. Thank you. But thank you so much for having me. This was a blast.
You're so welcome. Thank you. We look forward to seeing you soon.
Okay.
Bye.
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 Thank you for joining us on this episode of Talk the Talk.
We hope it was enjoyable and educational and further supports you both personally and professionally.
For more information, please check out our Wyo Myo and Myo Minute podcast, as well as our other episodes of Talk the Talk. And don't forget to check out our tongue training appliance, Spot Pal, to help with tongue thrusting, thumb sucking, snoring, TMJ, mouth breathing, and so much more. Visit thespotpal.com.